Good afternoon, everyone. Can everyone hear me?
Yes, Doc Jubert, loud
Yes.
and clear.
So welcome everyone to this session on addressing the TB reservoir through TB preventive treatment. It's time. So finally, yes, we have to tackle this issue as far as uh, possible giving TB preventive treatment, especially on our patients who have latent TB infection. This has been an on and off debate for how many years already, but I think we should grapple with the issue, especially now that we are being challenged to really hit our TB control targets. And I'm quite honored to be moderating this particular session with our esteemed lineup of speakers. Before we proceed further, let me remind everyone to possibly use our earphones or headphones to minimize background noise. Please post your questions using the Q&A box at any time during the meeting. It will be our policy to possibly go through the Q&A. If they are unanswered by the panelists, we can tackle them at the end of the session after all speakers have uh, done their part. Use the raise hand function and wait for the host to acknowledge and unmute your microphone before you can speak. If you encounter any technical difficulty or comments, you may post your query on the chat box or you may sign back in the meeting room. Everyone is encouraged to participate. So let's just focus at the moment, avoid multitasking, and to possibly really take this opportunity to hear from our great speaker. And of course, the session will be recorded for these purposes. So can I have the next slide, please? So as I've mentioned, we will be tackling a very interesting topic right now, LTBI, specifically looking at TB preventive treatment. I know there's a lot of questions as far as how to address it adequately. And so we will try to settle everything, especially once all the speakers have given their piece. I know it's going to be an interesting afternoon. Next slide. So being a past chair of the Philippine Coalition Against Tuberculosis, uh, it is it is an experience always to have some collaborative initiatives with both the private and government sector. And I do know that LTBI is really a nagging concern. It seems like our pediatric colleagues have at least address it well. But as far as adults are concerned, definitely there are some pros and cons. And maybe in the next few minutes, we will hear some experiences, some concepts, and possibly, how to implement this, especially in a programmatic or even in a clinical situation. Next slide. So let's go now to have this show on the road. I would like to, of course, uh, first segue to our objectives for this session to understand the current country situation and policy directions aimed at improving TPT coverage in the Philippines. I do know that's one of the targets of our national TB program. We would like also, of course, to hear experiences from our international colleagues, especially their success lessons on how to implement TPT on a national scale, possibly identify effective approaches or strategies in engaging private sector. We do need the private sector to be on the same bandwagon with us, know the role of certain tests like your IGRA, anchoring it or based on the context of the latest WHO recommendations on LTBI, and possibly looking at how will it be applicable in our scenario. and appreciate ongoing local innovative ways of telecontact tracing, especially during this time, and TPT provision during this COVID-19 pandemic coming off from a tertiary government hospital. So with those session objectives, let me now segue, of course, uh, to possibly welcoming our not just the participants, but always welcoming our uh, main panelists as well. So I think it is now time for the opening remarks. It is my honor to welcome Michelle Lang Ali to give the opening remarks. Michelle has been working for USAID as a health officer for more than 10 years, and she received her master's in public health in international health and development from Tulane University, including some coursework at Mahidol University in Thailand. So, Michelle, I would like to welcome you to the session.
Thank you. I haven't heard my background in a while, so that was kind of fun. So I'm really happy to be here, and thank you all for having us, having USAID and having me come and speak today. First, I want to give my greetings to Dr. Cleotilde Talley, who's the National Chair of PhilCat, to Amy Sarmiento, the Executive Director of PhilCat, our government partners, Director Napoleon Arevalo, the DOH Disease Prevention and Control Bureau, and our international and local speakers, partners, ladies and gentlemen. Magandang hapon po. So as we all know, TB is the world's deadliest infectious disease, although in the middle of COVID, it doesn't always feel that way. Each year, an estimated 10 million people fall ill with TB and 1.5 million die. In September 2018, we all know that the United Nations General Assembly high-level meeting on TB not only increased awareness of the disease, but it set the parameters for the next stage of the fight against it. At this meeting, heads of state committed to ambitious targets, including enrolling 30 million people on TB preventive therapy by 2022. And with the focus on countries with the highest burden of disease. The U.S. Agency for International Health and for International Development, USAID, we are firmly committed to supporting the Philippines National TB Control Program and partners in reducing the TB burden and improving the TB preventive therapy coverage in the country. USAID reaffirms that extensive TB case finding and effective TB treatment and massive provision of TB preventive therapy are key interventions that can significantly reduce TB incidence, even here in the Philippines. So thus, the revised Philippine Strategic TB Elimination Plan 2020 to 2023 redefines these strategies and targets of TB preventive therapy coverage and integrates the latest developments and guidelines in the investigation and treatment of latent TB infection. So as we all know, also in 2018, the Philippines reported an estimated 9,600 individuals receiving TBT, and that only TB preventive therapy coverage was 5% for contacts of bacteriologically confirmed TB patients, 9% in children who were household contacts, and 52% among those newly registered people living with HIV. So by the end of 2020, Philippines aims to target more than 680,000 individuals for TPT based on the latest PhilStat. So we still have a ways to go. So to address these challenges, USAID strongly supports the DOH in creating an enabling environment to support and maximize the implementation of TPT guidelines through innovative interventions, new TPT regimens, effective collaboration between the public and the private sectors, and strengthening policy, information systems, and funding mechanisms. With the assistance of USAID and its implementing partners to the government, private sector, professional societies, other stakeholders, we would like to reaffirm our commitment to supporting the country's TB elimination efforts, including addressing the TB reservoir through TPT. I congratulate Phil Catt and in organizing a timely webinar this August as the National Lung Month and the current COVID-19 situation. I am honored to open this session and I look forward to participating in a meaningful discussion on improving TBT coverage in the country, both in the public and the private sectors. Salamat po.
Thank you very much, Michelle. And we do appreciate you laying out certain challenges and, of course, hurdles that the country needs to overcome. And, of course, for renewing the partnership as far as collaborative initiatives with USAID. So let's now go to our speakers. The first speaker is tasked primarily to lay out the local roadmap as well as lay out or at least to share to everyone the country situation, especially the updates and revised targets for TPT. It's my privilege to welcome our first speaker, Dr. Alan Fabella, who has spent 8 years at the local government as a health center physician and subsequently became the CT NTP coordinator. Alan also had a lot of experiences with TB-related projects, being uh, being part of the as a public health specialist for the USA TB Project Impact from 2012 to 2018, and he's a current TB advisor of the DOH National TB Control Program of the USAID's TASC. Alan, let's hear from you.
Thank you very much, Dr. Joubert. So I'll be sharing my slides. Okay, so I hope everyone's seeing the slide.
Yeah,
so
it's okay. Yeah.
So on behalf of the NTP, I'll be presenting the situational update and roadmap for TB preventive treatment. So objectives have been stated by Dr. Joubert earlier. This presentation will cover 3 areas. First, we'll describe the TPT coverage for the past 4 years based on our prevailing policy or previous policy. Second, I'll describe the TPT roadmap, which is anchored on the National Strategic Plan called the Field Step 1. And third, I will just describe the major changes in the TPT policy and procedures as stated in our Manual of Procedures. So just to inform everyone that the Field Step 1 update and the Manual of Procedures 6th editions were both recently officially issued this April and July respectively. So going to the first topic, before I discuss the coverage, just to provide some context, this was our previous guidelines as stated in the 5th edition of the Manual of Procedures in 2014. So just to highlight the 3 important components there, in terms of the eligible groups for TPT, there were 2 main groups, mainly household contacts below 5 years old and persons living with HIV. In terms of the recommended procedure on LTBI screening or testing, the recommendation for child contacts is to do a tuberculin skin test. However, noting that it is a common program barrier or limitation, the availability of TPD, there is a provision that if TST is not available, the contacts of bacteriologically confirmed index cases below 5 years old may still be given TPT. For persons living with HIV, there was no recommendation to do TST other than to exclude active TB. And then as far as regimen is concerned, we are just giving one type of regimen, which is 6 months of isoniazid. So as we look at the coverage in the past 4 years, the blue line here, the blue graph represents the estimated proportion of eligible child contacts that were given TPT, while the orange bar represents the estimate proportion of newly diagnosed HIV patients for the year that were given TPT. As you can see, across the 4 years, for household contacts, it's all between 5% to a little over 10%. So only a small proportion of potential eligible clients were given TPT. For PLHIV, it's between 40 to about less than 60%. So the source of this is the WHO Global Report. We don't have yet the official WHO report for the 2019 data because this will be in the 2020 Global TB report in a few months. But as far as the TB report is concerned, the following are the information. We have initiated into TPT approximately 12,051 persons. So that would be approximately 4% of eligible contacts and about 55% of the PLHIV. So basically, the coverage with TPT is very low for the past 4 years, and that is a main challenge for the program. So what are the possible reasons? In October of 2019, a joint program review was conducted, which involved visiting more than 50 facilities and doing a qualitative assessment of the different program components. So for TB preventive treatment, the following are the major issues identified. I think the major reason identified is there is generally low priority accorded to TPT at all implementation levels. So the focus has been on finding active TB cases and ensuring successful treatment, and TPT tends to take a backseat. Bullet number 2 and number 3 are related to our previous procedures, wherein it's stated there that TPT among older contacts and other risk groups are not currently included in the procedure and hence not implemented. And then alternative regimens, specifically shorter regimens, are also not available. There was also an identification of various health system issues, such as erratic supply of PPD, multiple tasks, and often with competing responsibilities among health workers, and then suboptimal engagement of the community and the private sector. So these are the challenges that we aim to address moving forward in our strategic plan. So before I go to the field step, just to emphasize that even as early as 2015, with the release of the NTB strategy, the global strategy to stop TB, it was already emphasized that in order to decrease incidence rates to levels that will be required to end TB by 2035, we need to mainstream treatment of latent TB infection. So that is actually one of the core components of the Pillar 1 in the NTB strategy, which is preventive treatment of persons at high risk. So taking off from this, even in the original field step of 2017 to 2022, TPT has been one of the major program outcomes that we desire. Here you see the updated field step 2020 to 2023. And just to highlight that in addition to our usual outcome indicators of case finding and case holding, TB preventive treatment coverage is already an important outcome indicator. So from a baseline of 5 to 10% for contacts and 50% for PLHIV, we want to increase it to a total of 60% of eligible being reached by TB preventive treatment. So these are the annual targets. No? You can see that these are indeed very ambitious targets. We are beginning from a baseline of about 12,000. We want to have a total annual TPT coverage of about 300,000 by 2023. Of course, understandably, we met a very big roadblock this year because of COVID pandemic that has disrupted many health services. But hopefully, in the span of 4 years, we are able to reach eventually our goal of getting 60% of contacts on TPT and 90% of PLHIV. So overall, that is 685,000 from 2020 to 2023 based on TB preventive treatment. So the strategy statement in field step is put simply as to adopt short TPT regimens. So that is our strategy statement, although included in that is not just adoption of short regimen, but really increasing coverage and uptake through various strategies. So these are just some of the activities stated there. but I'd like to focus on the roadmap for TPT strategy. So the field step is the overall strategy for all TB components. But for the TPT, we have detailed, or we are trying to detail the specific strategies in a roadmap, and that's what I'm going to describe in the next few slides. So the TPT roadmap is currently being developed. It has been presented once to the sub-technical working group, and a series of consultations and development meetings have been coordinated or led by one of our implementing partners, TB Innovations. And basically, there are four major components in order to reach 685,000 by 2023. These components include implementation of innovative TPT strategies, adoption of the new TPT regimens, public-private collaboration, and health system strengthening. So for innovative TPT strategies, our focus is for the contact investigation to be integrated in all case finding activities. So whether it be active case finding or intensified case finding, we should not stop at detecting the active TB case, but once a case is identified, we immediately proceed with investigation of contacts. And this should be integrated in our ACF and ICF activities. There are two models there that are to be explored. One is LTBI screening in congregate settings. So you will see later, it's not currently part of our strategy to do mass LTBI screening in prisons or jails. However, this is something that can be explored as part of our innovation or pilot. And then we also have some initiative on TB case finding, such as the TB-free island. I know there is an initiative in Region 4A on TB-free island, and the challenge is to go beyond active case finding, but to consider also LTBI screening and TPT as part of the initiative. For new TPT regimens, actually the major interventions here are all about improving the efficiency of procurement and supply chain management systems in order to make available the shorter TPT regimens, specifically 3HP. So all these are geared towards ESCM improvement. For public-private collaboration, we have a strong collaboration already between DOH and the professional societies mediated through PhilCat, particularly in the implementation of mandatory notification and other PPM strategies, such as hospital engagement. So the plan is really to include TPT in that collaboration, which will include dissemination of TPT guidelines in the private sector and expansion of our current mandatory notification to include not just active TB cases, but latent TB infection. And finally, health system strengthening, our intervention to improve governance through establishment of National Coordinating Committee, to intensify social behavior change through advocacy and promotion, improving LTBI information management to get better data for decision making, and capacity building of all health workers. So going now to the last portion of the presentation, to achieve these strategies, we had to adjust also our policies and procedures on patient care. Actually, even before the MOP or Manual of Procedures was released this year, middle of last year, the DOH already issued an advanced policy which expands eligibility of LTBI treatment to several other high-risk groups. So this memo has now been integrated into our latest Manual of Procedures, wherein one chapter is devoted strictly to TPT. So definitely TPT is a program priority and part of our top indicators together with case notification and treatment success. So what are the major changes? No? So I would like to highlight the changes in relation to our previous guidelines. So before, we only had 2 eligible groups. Under the new MOP, these groups are all still included, but in addition, we have expanded to the following. So now, we are recommending that household contacts above 5 years old should also be assessed and may also be given TPT. The caveat here is we are focusing on contacts of bacteriologically confirmed TB cases if they are above 5 years old. And then we are further expanding to close contacts outside the household. So close contacts of all ages of a bacteriologically confirmed index case are also eligible. And finally, we included 4 additional clinical risk groups, mainly patients on dialysis, those for organ or hematologic transplant, those on anti-tumor necrosis factor treatment, and those with silicosis. So these may not be common occurrences, but I think for those who are practicing in specialty centers or specialists, these are important new inclusions in the eligible populations for TPT. In terms of how to assess, do we require tuberculin skin test for all? So there is now a revision also. There are some high-risk groups wherein TST is not a required procedure anymore. So the program deems that the risk of progression to active disease is very significant regardless of whether baseline TST is done or not. So for PLHIV, child contacts of bacteriologically confirmed TB case, and then contacts more than 5 of bacteriologically indexed case who have other TB risk factors, then these may be considered already for TPT once active TB is rolled out. The other risk factors stated in the MOP are diabetes, smoking, immunocompromised clinical conditions, malnutrition, and having more than one TB case in the household other than the contact being screened. So for these patients, TST is not a required procedure anymore because the risk is already deemed very significant for progression to active disease. For the other groups, the TST or IGRA is recommended. So that's one revision also that TST or IGRA may be used, recognizing that many partners, especially from the private sector, are using IGRA. So for these groups, less than 5 contact of a clinically diagnosed index case, more than 5 contact of a BCTB, but with no other risk factors, close contacts, and clinical risk groups, TST or IGRA is recommended, and TPT is given if positive on this LTBI testing. Finally, in terms of regimen, we have already expanded also. In addition to the 6 months of isoniazid treatment, program recognizes that shorter treatment regimens are have been shown to have less treatment interruption and higher rates of treatment completion. So we have alternative regimens which may be eventually mainstream once it is available in the country. We have the weekly dosing of isoniazid and rifampicin for 12 doses. So that's just 12 weeks or 3 months. Daily isoniazid and rifampicin, and then 4 months of rifampicin. So these are now the shorter regimens which have been recommended and are usually preferred in terms of adherence and treatment completion. So there are other sections of the guidelines on TPT in the MOP. It's not part of the current presentation, but you can access the MOP document in the DOH website. So in summary, we have shown that the coverage of TB preventive treatment is very low, about 5 to 10% for child contacts and about 50% for PLHIV. But we do recognize that reducing TB incidence requires mainstreaming TPT into the program. So it's not just case finding for active TB, but TPT is now equally important. The Philippine Strategic Plan has set ambitious targets. No? So from 5%, we want to reach 60% eligibility coverage among contacts. And from 50%, we want to reach 90% among persons living with HIV. The TPT roadmap is our guide for implementation and to reach the targets. And hopefully we can finalize this soon. And then NTP guidelines for TPT reflected in the revised manual of procedures has likewise been revised to match these strategies. So that is all. Thank you very much.
Thank you very much, Alan, for that concise presentation. Indeed, it's a Herculean task, if not ambitious, as what you have stated, that we have laid out finally TPT as one of the integral aspects of the program that we have to contend with. And I do like that you acknowledge the tasks that need to be done and that need to be accomplished, and of course the needed collaboration. And I am excited as far as the shorter regimens are concerned. So let's now move on. Since Alan laid out what is it ahead of us from the Philippine side, may we now call on Dr. Lisa Stevens. Lisa brings technical expertise across many countries. She has been a senior technical advisor for TB and HIV with FHI 360 for the Asia Pacific region based in Bangkok, Thailand. So her interest really lies in TB and HIV activities, including diagnostics, care, and treatment. So to give us some background or some update as far as improving TPT coverage at a national scale in other countries, and maybe we can learn something really that can be applied in the Philippines as well, may I now call to the floor Dr. Lisa Stevens.
Thank you very much. I've turned on my video so you can all watch me struggle with the IT part of this, which is always fun. I've just requested to control my own slides. Let me just see if that, maybe it's not working. I'm gonna give up remote control and let you all control my slides. I think it might be safer that way. Anyway, so thank you very much to the organizers, to Dr. Joubert, to Michelle, and all the other people that have helped pull this together. Thanks for inviting me to join this symposium on TB preventative therapy. I'm really excited to share what's happening in some other countries. We know that TB preventive therapy is a really important part of the armamentarium. As Dr. Allen talked about, if we're going to reach the goals we have for TB elimination, we need to do something about this reservoir of latent TB infection. So during this talk, I'll just briefly talk on where we are globally, looking at the goals laid out by the UN high-level meeting, and then move on to talk about the progress, especially in the three groups. We'll kind of break it down by the three target groups. Then what are some of the obstacles and how are other countries working through delivery models, and what are some of the examples of some of the more successful countries with TB preventative therapy. So here, as Michelle mentioned, there was a high-level meeting of the UN, which was dedicated to TB in 2018, where we set up goals. And you can see on this slide that our the orange arrow for TB preventative therapy is kind of the smallest one up there. So we've got, as a global TB community, we've got a ways to go to reach those 30 million people that Michelle mentioned. If you break that down into groups, there's actually three groups, as we've heard about. The first is people living with HIV, which we have a target of 6 million people by 2022. Then the under 5 children who are exposed to TB in the home, and the target on that one is 4 million, which leaves 20 million people from the other contacts. So those are children over 5 years and over, and adults, 20 million that are supposed to be started by 2022. So if we go to the next slide, we can talk about how we're actually doing. Where do I go? Oh, you've got it. Great, thanks. So from most of the data in here, as Alan mentioned, Global TB Report is a little bit behind, but that's kind of what we have right now, although we've got a nice sneak peek into Philippines data for 2019. So in 2018, which is what we see in the 19 report, only 49% of all people newly enrolled in HIV care were started on TPT, and only 27% of those children under 5 who were estimated to need TPT actually got started. So we have the PLHIV target is actually, people are thinking we're gonna reach that. 1.8 million people started on TPT from who are also living with HIV in 2018. But there's a big range from your neighbor Indonesia with the lowest among TB high burden countries of 10% to the Russian Federation, which was almost 100% of all people living with HIV. So HIV, we're approaching it, but it gets much worse when we look at contacts. For children, there were estimated to be 1.3 million children who needed TPT under 5 in 2018, and only 350,000, so less than a third actually received it. And it's even worse for the older contacts. Less than 80,000 people received it, and we're supposed to be up to 20 million by 2022. So there's a long way to go on getting TPT to contacts. So we'll talk about all three of those groups and what we can do. Let's move to the next one. So among people living with HIV, you can see there's been a huge acceleration in the last couple of years. A lot of that has to do with PEPFAR programs really focusing on TB preventative therapy, and our colleagues in the HIV, national HIV programs are really pushing to make sure people with HIV are getting treatment for TB latent infection, because we know they're really at high risk, with a quarter of all, or a third of all HIV deaths, or 250,000 people dying from TB who have HIV. And we know there's something that can be done to help reduce that. You can see South Africa is kind of highlighted here because they've actually done the best. So we'll talk a little bit about the programs in South Africa and how they've accelerated. You'll also see a really big jump in the last couple of years. Most of that is effort, but they've also started recording not just people who are newly enrolled in TB care, in HIV care, but also all people in HIV care. So the numbers are starting to increase. Next slide. So if you look at some of the higher incidents, higher TB incident countries, and look at the how we're doing, this slide's a little bit misleading because green is bad. And normally we think of green as go and green is a good thing, but green is our gap. And you can see Philippines is way over on the right with a smaller gap than a lot of these other countries. This is only looking at those with HIV, and you recorded a pretty high percentage looking at it globally. But again, compared to Indonesia, you have about the same percentage of people in the orange, and those are people who are found to have active TB disease. But your preventative therapy for HIV is so much higher that your gap overall is smaller. So kudos to the Philippines. We'll go to the next slide. Okay, but what about children under 5? So this slide looks at what's coverage for TPT for the under 5s, and the darker the blue, the better the country's doing. So you can see most of the dark blue are in countries that maybe aren't the highest risk, and we've got kind of a long way to go to reach the goals. Yeah, so we're falling short. The highest numbers of children actually come from India, then Mozambique, South Africa, and Bangladesh, at least in 2018. And as we heard from Dr. Allen, you guys are at a 9% coverage for the Philippines. That was in 2018, and I think he just reported a lower coverage, it was 4% for 2019. The next slide. So looking at other contacts, household contacts, those 5 years and above, we know this is kind of newer in the WHO recommendations from 2018, but countries are gradually incorporating this into their guidelines and starting to implement this. But as we mentioned, the numbers are really low. In many countries, the total contacts that started TPT are actually equal to the under 5s, meaning that nobody is getting it except for the under 5s and the PLHIV. So this call to action, which was signed by many of big organizations, including USAID, UNITAID, WHO, UNICEF, mentions that we really need to work to achieve these targets, especially in household contacts. Also, as will be mentioned probably in every webinar you hear in 2020, COVID is a challenge for contact investigation and for reaching these contacts. But nevertheless, we've really got to work hard on this area especially. Next slide. Thanks. So mostly we talk about TPT coverage. Those are the numbers that we quoted from the Global TB report, but there's really three main areas to look at as far as indicators. The first is how are we doing with contact investigation? And again, this was mentioned in Dr. Allen's presentation, that linking contact investigation to all of your active case finding is going to help make a difference. If we're not out investigating every single bacteriologically confirmed TB case, we're missing opportunities. So TPT coverage is what we've been talking about, those who start. But I just want to focus for a second on the last one, TPT completion. We know that many countries and in many places, TPT completion is not fantastic. It can be as low as 30%, as high as maybe 70%. And a lot of that has to do with regimens. Most countries are using isoniazid for 6 months, and some use it even longer than 6 months, 9 months or 12 months. But we need to come up with shorter, better regimens, work on adherence, and try to make it easier for patients to complete treatment. Next slide. Next slide, please. There we go. So some of the obstacles to TPT scale up, the first is that reliance on TST or IGRAS. If you've got to do the diagnostic test for LTBI, you may have problems with supply, with training, with getting patients to come back a few days later to read their TST. Or for the IGRA, I think we're going to hear more about it, but just having the lab facilities and the cost associated. I won't go through every single point, but just a few. The second is being able to reliably rule out TB disease. So having access to chest x-rays, again, they're not always required, but definitely if you can get them, better. And there's concerns about isoniazid resistance if you're not doing a good job at ruling out active TB. There have been numerous studies. None of them yet have shown any statistically significant increase in resistance, but I think that's something we do need to look at as this is further rolled out. And as we use other combinations with rifamycins, with rifabutin or rifampicin, hopefully we'll see, again, we'll be having less concerns about isoniazid resistance. One size fits all option. I think it's one size does not fit all. So having different options, having the 3-HP available along with isoniazid, or even the 1-HP option, which only lasts for a month, are important. And then I'm just going to point out the supply chain management. So this comes up, you've already mentioned it, but you hear it from many countries as they're moving towards scale up, that supply chain is really, really important. Go to the next slide. So what are some of the TPT delivery models? You are now trying to reach 60% of your contacts and 90% of your PLHIV. And I think you've got delivery models in place, but maybe there's more you can think about, more we can talk about from other countries. So the traditional approach is somebody's sent into the clinic because someone in their house has got TB, and they're evaluated, started on medicine, asked to come back repeatedly, pick it up every month, and hopefully they'll finish. Other options are to use community health workers, community-based delivery. It could be a lay worker who checks for side effects, checks for signs of TB and refills, maybe even having it started in the community. And then the final is using community-based treatment groups, which are pretty common in HIV programs, especially in remote areas where maybe one person from that community or village goes to the health facility and picks up refills for many people. So there are different options and ways to think through, and probably in a country like the Philippines, you're going to need more than one option, as it really varies across the geography. The next slide. So just to talk for a minute about what South Africa has done. So South Africa in 2018 actually had 61% of everybody getting TPT in the world lived in South Africa. They've done an incredible job at scale up, and they did their scale up by coming up with the Department of Health together with the TB think tank, which is basically a technical sub-working group, put together a plan, and all the partners got in there and worked on it. So They had targets along their cascade of care, starting with the case finding to make sure that all, or greater than 95% of PLHIV are screened for TB, and that all household contacts get screened. So I think that's the first sort of rate limiting step. If you're missing all of these people out there who are possibly needing the services from the beginning, your numbers, you're never going to reach those targets. Then next is to actually start as soon as possible. So their targets are to start TB treatment within 7 days, and also to start treatment for LTBI or TPT within 7 days. They made both isoniazid, and they're working to scale up 3HP across the country. So having both options available for contacts and for PLHIV. And then they're aiming at a 70% or better than 70% completion rate. Next slide. So what did they do? They had special interest groups. There's a lot of treatment action groups and people, especially working from the National AIDS Program side, but a lot of advocacy to drive this forward. They developed guidelines and scale-up plans, much as you all have done, pulled partners together, and then worked on providing tools and looking at this on a weekly basis. So they had a weekly dashboard, weekly nerve center, and were monitoring really closely. And that's kind of more than most of us do for TB treatment. So really deciding that this was a priority and moving it through, I think, yeah, there's lots we can learn from them. So another piece, if we go to the next slide. They did a trial in KwaZulu-Natal of community-based TPT. They actually added this to a study that was going on community-based ART. They integrated isoniazid preventative therapy, so TPT. So the community-based program was delivering ART with lay health workers to the home, giving quarterly refills of ART already, monitoring mobilely, and only sending people to the facility if they had some sort of need. And within this study, they added IPT to it, started IPT 1 month after ART was started, and synchronized the refills. So they gave quarterly refills on IPT. They achieved really high adherence, high uptake, and great continuation rates. So the thought in that community-based IPT actually did better than clinic-based IPT. So just something to think about in the different settings of your country. Next slide. So Tanzania is another success story with TPT scale up, especially for PLHIV. They worked on capacity building with trainings and then a lot of on-site mentorship, developed a quality improvement program where they reviewed charts and looked closely at TPT registers. There it was monthly, not weekly attention, but they also invested a lot into their supply chain. So they decided that every clinic that had a lot of people on ART would have enough isoniazid available for 50% of the ART clients to actually be on it. So they really worked on stock management. Like everywhere recently, they've had to mitigate COVID-19 and move monitoring to remote, and then added in multi-month dispensing, which is big talk in the HIV world. We don't always use those terms in TB, but trying to decongest clinics by not making people come back every single month. So they were doing that with their ART, and they added TPT with that. And I've heard our team in Mozambique did the same thing and actually ran into problems with supply when they started giving out 3 months isoniazid. In some places are giving 6 months of isoniazid. So you just have to make sure that your supply chain is ready for that. Next slide. So what they then achieved. So this is just this year. They had pretty rapid scale up. You could see on the slide on the right from March, there was a drop, and that had to do with supplies running out. So they had to stabilize their stock in Q2. And then accompanying this was a really good completion rate. Actually from fiscal year 19, the year before, their completion rate was about 47%, which is not good. But they were up to 90% by this last quarter. So with all the extra effort, they were really accelerating, starting and keeping people on treatment, which is important. The next slide. This is just quickly an example from Uganda with our colleagues at URC and the Defeat TB program, set up a surge plan to try to accelerate isoniazid preventative therapy over just 100 days. So they used some of these same things. They used a scale-up plan, some tools, implementation, coaching guides, and they really went out for quality improvement to the sites and got the local and district leadership involved. And they managed to put over 300,000 people on TPT in this short period of time. So that's, I think that's your goals for 2022 or 2023 or something. So lots of lessons to learn from our colleagues at URC who maybe can tell us more. I'm sure there's some of them on the call. Next slide. So most of those are examples from PLHIV programs. And I mentioned that there's just been a big push from PEPFAR and others. But where you're struggling and where many countries are really struggling is the under 5. So how are we, or the contacts, how are we going to find these under 5 contacts and other contacts, and how are we going to get them started and keep them on? So Nigeria had a success rate in 2017. Their rate was up to 67% uptake of TPT under 5, which is very high globally. And you can see this was a Challenge TB project, had invested a lot into contact investigations. And the orange bars on there actually showed before Challenge TB started working, and you can see that the black is when they began contributing, the rates just greatly increased, and it all had to do with really focusing on contact investigation and making that system work, where whoever they found actually got in, got evaluated, and got started. So next slide. So I was, the next slide, yeah, in Cambodia, I was involved in this. This was Challenge TB, and we decided to bring IPT to the people. So teams of healthcare workers and volunteers, which were part of their village health support groups, would go out whenever they found a bacteriologically confirmed TB case and assess everybody in the home and some of their close neighbors who they spent a lot of time with. And they actually, in their backpacks, had isoniazids. So they had a health worker there. They would ask the questions and look the child over. And if they were healthy, after counseling, get the babies started right then, the small children. And, you know, just from this program, we put over 6,000 kids on TPT, also found a lot of active TB through the contact investigations. But one of the issues before we started was, and you hear this from so many places, that parents don't want to put healthy children on medicine. But actually with good counseling and people they trust from their own community, we had an 80% acceptance rate. And I'm hoping that now, a year or two later, that's actually even higher. Next slide. So that's uptake in general, and I think I just want to put a plug in for the 3 months of isoniazid rifapentine. I think we can do a lot better if we have shorter, better regimens. If we can get down to 3 months or even 1 month, people are more likely to accept, and people are definitely more likely to complete. This is again from the Global TB report, showing that there were 21 countries reporting to be using rifapentine. And I think there's a lot more that are geared up to start. A lot of people like the Philippines, or a lot of countries have added it to their guidelines. But this is a new tool that we really need to maximize on and make it more available. So thinking not just about numbers, but what regimen we're using, so we can get more than just initiation, but we can also get completion. Next slide. So just as a few take-home points, we know that TPT uptake in PLHIVs are accelerating, but household contacts are lagging behind. To reach that goal for the over 5s of 20 million people by 2022 is going to be very challenging, and every country is going to need to figure out how their part of that happen. There's lots of successful stories, both facility and community-based approaches from other countries. Linking to other programs, like linking your TPT to ART and definitely to contact investigations, is crucial. And 3HP scale up is likely going to enhance uptake and completion. And my final last point is that I know how well the Philippines does with introducing and scaling up new innovations and better interventions and treatments. And I'm really excited to see your future success now that you've got your roadmap, your new guidelines, new regimens. And I imagine you'll soon have lessons to teach the world on TPT scale up. So last slide. Just one more slide. Thank you. Thanks.
Thank you very much, Lisa, for that wonderful talk, and indeed for sharing with us valuable lessons that we can learn from as we go on and pursue that roadmap that Alan presented earlier. Before we proceed further, let me just remind the participants that for any questions, please type it in the Q&A panel, not the chat box. And I would like to encourage, of course, the panelists to always visit the Q&A panel, especially after your talk. So maybe if you can answer some of the questions that were written down there, we can possibly have a better time management, so we can really allot more time during the open forum for other unanswered, possibly interesting topics as well. So for the next talk, let me welcome Dr. Hamida Hussein. She is a public health professional with over 2 decades of experience in global health and epidemiological research, and had intensive work especially on active case finding for susceptible and drug-resistant TB. Dr. Hussein is also currently a global technical lead for interactive research and development TB program focusing on TB preventive treatment. So it is indeed my pleasure to welcome Dr. Hamida Hussein to possibly talk on what is really important. I think one of the ingredients, private-public coordination effort in order to increase TPT. Dr. Hussein, the floor is yours.
Thank you very much, Dr. Jubert. Okay, I'm going to try and take control over my slide. So I'm going to talk about our work in 2 countries, in Pakistan. Both of those 2 countries introduced 3HP on a limited scale through the private sector, but in partnership with the public sector. So I'm going to talk, and I'm going to base my talk very practical and very hands-on to see what the country needs to do to engage the private sector. Thank you. For some reason, my keyboard is not responding to the remote control. All right, so the first experience is going to be from Pakistan. Next slide, please. So the Pakistan program is based under the umbrella of what we call Pakistan's Zero TB initiative. It is supported by the Global Fund. It was initiated in 2016 and in one city of Pakistan, which is Karachi, which is the largest city in Pakistan, and 32 rural districts. It was later extended and expanded to 2 other cities of Peshawar and Quetta. So now we are covering 3 provincial capitals in Pakistan, plus the 32 districts that we had. This is a map of Pakistan. And for those of you who are perhaps not maybe very familiar with Pakistan, on the right hand of the slide, you would see the TB statistics for Pakistan. Pakistan has a high incidence of 265 people per 100,000 population. This map of Pakistan, I want you all to focus on the bottom of the page, which is the province of Sindh. And within that, the city of Karachi, where we first initiated the program, it has a small ballooned out yellow highlight, which you can see. What in this city we did? We provided comprehensive care for tuberculosis, which included actively searching for people who might have tuberculosis, whether they presented to public sector or to the private sector. We offered them X-ray through mobile X-ray vans, which roamed the city of Karachi as well as supported the hospitals. 7 of these sites actually provided and became specialized child TB sites. Of these, the same 7 sites also became specialized in providing preventive treatment, in particular with 3HP. So this was a lot in addition to the IPT that was provided by the government sector. 31 centers were opened up, and these were completely private centers. They were called Sehatmand Zindagi Centers, or SZC. It's a Urdu terminology, which is the national language, but it essentially means good health centers. So these centers took healthcare and particularly TB care very close to the community. From all of these facilities, we had 3 facilities that provided care for drug-resistant TB. One of the biggest challenges in Pakistan is that the health sector is divided into public and private sectors. So the private sector comprises of large hospitals and small hospitals. But in addition, there is a very large component of single physicians providing care in very small clinics, very close to the community. And that is where the majority of the population first access care. So this initiative engaged more than 1,400 of these GPs and involved them in the TB care in a manner that they would be able to identify and report TB patients into the government system. The blue on the map you see is throughout Pakistan, where all the active case finding approaches are now working in Pakistan through the private sector initiative. Up onto the right-hand side of the screen, it's left-hand side of the screen, sorry, where it says Peshawar. That's the second city that came on board for the active case under the Zero TB umbrella. And the third city, Quetta, is now gearing up and becoming another Zero TB site. Next slide, please. So I'm just going to talk a little bit about the active case finding approach before going on to the preventive treatment side. As Dr. Ellen initially mentioned that, you know, until you have the patients, you cannot find their contacts. So it's very important for us to actually find all the TB patients. And for that, what we did is we involved all the private and the public sector hospitals within the city of Karachi. That's where I'm primarily focusing this talk on. The public sector sites, or even some of the private sector sites, hospitals, cannot support the number of chest x-rays that might be required to identify patients. When we screen patients who come to the outpatient clinics, whether they're coming to orthopedic clinic or to the ophthalmology clinic, we were screening every patient that's walking into the hospital's outpatient clinic. But that kind of x-ray support, the hospital perhaps cannot bear or provide. So what we did is procured these mobile x-ray vans and we branded them. Very important to lower the stigma in Pakistan was to brand and make TB screening very just as any other disease screening. So we invited one of our national sports hero in cricket to be the face of this campaign, and he kindly agreed and donated his time to the effort. Then we also went through a long process of branding the slogan and coming up with the slogan. And it's on your screen, you would say on the van, it says, "Ao TB Mitao." It's "Ao TB Mitao." It literally translates to "Come eliminate TB." And the fist, the three fists, denotes the community and working together. Next. The different approaches for the active case finding we did is to do hospital outpatient clinics. On the top right-hand corner, you see a photograph of a very busy hospital, which has a van parked outside and people were coming in and out to get their x-rays. Then you had community-based camp, which you see on the bottom right corner, where people were lining up under a shaded tarp, and the vans, 2 vans are parked. This was primarily a camp geared towards ladies, to the female population. And prior to the camp, we would certainly do some community mobilization, and which would help bring the people out and get themselves screened for tuberculosis. Similar to these community camps, we had camps at the industries, in prisons, and any other congregate settings where we were allowed to screen people for TB. In these vans, we had a digital CAD4 TB x-rays mounted. So anybody who had a score of more than 70 were then further evaluated for tuberculosis. Good thing about with these vans was on your left-hand side of the screen, the photograph with the microphone and the camera shows what happened is that once these vans were parked in multiple different communities, the television crews came to interview and find out what was really happening and what these camps were. So a lot of publicity was garnered, which was provided free of charge by these television networks. And that helped in making TB screening more mainstream. Next slide, please. Now this brings me, so now through those active screening models, we have identified all the index TB patients, and that brought us to contact investigation and preventive treatment and how we went about that. Next slide. Before starting the contact investigation and programs, we started in October 2016. And that was before the WHO guidelines recommended contact screening for the entire household. This is where we started our program. So the first, we came up with an SOP, we came up with training modules and materials and the counseling guides that were required. We recruited dedicated staff initially. As you all know, that doing a full household contact investigation is not easy, and the current staff are already stretched that are present in the TB program. So we had to recruit dedicated staff. We gave them 2 days of interactive training in all the aspects of TB disease and the regimens and adherence practices. We also gave them hands-on training by placement for one-on-one training. Then the rest of the hospital staff, wherever these preventive programs were initiated, the rest of the hospital staff were also orientated. So they knew what was happening, and this was going beyond the children under 5 and people living with HIV. We created strong relationships with the PTPs and the NTPs. PTP stands for Provincial TB Control Program, NTP for National TB Control Program, and each of the hospital and the community that we were working with. There was no data collection tools except for those focused on children under 5 and people living with HIV. So we had to develop extra and additional data collection tools. We digitized all our data collection tools into a mobile app. We pilot tested the app and rolled it out. And of course, had to develop site-specific process flows. Now, as 3HP was being introduced in Pakistan for the first time, we had to create a clinical experts group because it was, again, not in WHO recommendation when we started out. Hence, we had to ensure that if we run into any adverse events, we would have the clinical expert panel to help us in that process. Next slide, please. This is the process flow that we followed. So once we had the index TB patient, we identified that person. Right at the same time of the index patient initiating TB treatment, we enumerated the household contacts by interviewing the index TB patient. Once we had enumerated, we really counseled them to bring the family members to the health facility so we could do screening for TB. All people who came to the health facility were symptom screened. All contacts were provided with a chest x-ray. So they all underwent a chest x-ray and a medical consult. If they could provide a sputum specimen, then we tested that through GeneXpert. If an active TB disease was found, they were initiated on treatment. If no TB disease was found, then we offered them preventive treatment. And of course, it was on the patient on the contacts if they would like to start the preventive treatment or not. Next slide, please. So the regimens that we followed were for drug-sensitive tuberculosis contacts, 0 to 2 years received INH as per the national guidelines. Anybody above 2 years of age to the adults received the once weekly 3-month isoniazid and rifapentine combination, or 3HP. We also provided preventive treatment for the drug-resistant TB contacts, and that was given as a combination of levofloxacin and a secondary drug of either ethionamide or ethambutol. Next slide, please. I think previous speakers have mentioned the importance of counseling, particularly Lisa mentioned that. Counseling played a huge part in our program as well. For the index TB patient as well as their contacts, they were counseled on their initial and baseline visits. Once they initiated the TB treatment, a 2-weekly adherence call went to contacts to help support them continue on with the treatment. And then at every follow-up, which was monthly follow-up for those on 3HP, they also received counseling during their monthly visits. And the counseling was mostly done on tuberculosis, its mode of transmission, risk to close contacts, importance of screening, importance of starting preventive treatment, and importance of adherence and completion of treatment. Next slide. I mentioned earlier that electronic data capture, we created a platform for electronic data capture because these were not available. So this is just some slide and screen captures for those. There was a clinical contact screening form. There was an infection treatment eligibility form, then treatment initiation forms, and so on and so forth. Next slide, please. This is some of the data that I would like to show, and this goes more to the point of saying that how important shorter regimens are. What you see over here is a data from October 2016 to March 2020. We collected our data on a care of cascade format. So we started in total, we started 17,000, a little over 17,000 people on preventive treatment, including both INH and 3HP. Till March 2020, before the COVID pandemic hit, we had treatment outcomes available for 77% of the people, and we had a treatment completion rate of 72%. However, when you break this down of 72%, what you see is INH has a much lower treatment completion rate than 3HP. Sorry, my slides just disappeared. Gibo? Can I have my slides back? Hello?
Can we help Dr. Hussein with her slides? Her slide just suddenly disappeared. Can we have the backup slides of Dr. Hussein?
I was using the slides through your master slide deck. I'm not sure what happened. They just suddenly disappeared. Is there someone from the IT department here who can bring my slides back on?
Hello, Lalaine or Gibo? Can we can we have the slides back, please?
Jubert, we're encountering some technical difficulties. Can Dr. Hamida share her slides from her deck?
Yeah, I can try and do that.
Okay. Sorry for that.
When I'm panelist, it doesn't give me an option to share my screen.
Yeah. Can we have the host give that option to Dr. Hussein so that she can share her screen?
It says all panelists, but it doesn't go to the next step.
Gibo or Lalaine? Can someone please help Dr. Hussein with her slides?
All right, it seems we are back on. Next slide, please. And the next. And the next. So it's done with the slide when it disappears. All right, so I also have a very short time left, so I'm going to go a little fast. In terms of what we saw was that why were people refusing? In the previous slide, you might have seen we had about a 16% people who stopped treatment after they initiated treatment. So some of the reasons that were we found for those refusals were refusals at the disease evaluation was because of the work and the academic schedule, or information that the family or the relatives were unaware of the index TB patient has TB disease. There is a lot of stigma about TB in Pakistan, hence we had to be really careful about informing the families of the TB patients. And of course, these are healthy people. When they come in for their evaluation, they don't want to wait at the hospital too long. So if there is a long wait time, that puts the people off into initiating the treatment. Once they had gone through the evaluation, and then why did they stop taking treatment or refuse the treatment? It was because they were non-symptomatic, or if the index patient was non-adherent, or if anybody in the household who had initially started preventive treatment encountered adverse events, or if the index patient died during the treatment. Once they start the treatment, then primarily it was the adverse event that led to the refusal. Next slide, please. As we encountered refusals and as we understood the program implementation and the challenges that we were facing, we initiated a call center, which really facilitated the patients and reminded them about their upcoming visits, rescheduled if there were missed appointments, and helped ensure adherence for for patients who are on treatment by giving them counseling sessions just on basic counseling methods, and identify any challenges and report to the program management if a certain patient is, if they felt that about to fall through. Next slide. Still, as you expand 3HP, I think the challenges will remain. There is not always equitable distribution of health facilities and health infrastructure. So there is poor access. There are communities which are hard to reach and they're more vulnerable. As well as through the preventive program, 3HP, even though it has only 3 or 4 health visits, still those are multiple visits, and the wait time at the health facility puts people off because they have to take time off from work. Next slide, please. Very quickly, I will give you 2 or 3 slides for experience from Bangladesh, which was slightly different from Pakistan. Next slide. So after our experience in Pakistan, as we started the program in Bangladesh, what we did is to do a qualitative study first to understand what were the what were the perceptions of preventive treatment, both at the level of TB patient, at their contacts, as well as the health policy. So what we found is that majority of the time, the TB patients, as well as their contacts, actually appreciated the idea of prevention. They understood that, but they relied on their doctors and said, at least for Bangladesh, that if the doctors recommended them, then they would take it. They showed preference for a shorter regimen than for any long-term regimen. Next slide. The health policy people, or who we call over here the key informants, talked about that this is the important way forward. They all wanted to start 3HP as a pilot. Again, this is a time when it was not a recommendation from WHO at this point in time. And the cost of 3HP and the funding for 3HP were the major barriers that were identified, including challenges with HR and how they're going to tackle the contact investigation for the entire households when to do it for children under 5 is a challenge also. Next slide. So with this, we initiated the contact investigation in Bangladesh and preventive treatment with 3HP as a small pilot. What we did differently here is that instead of asking people to come to the health facility, we engaged the smaller NGOs which had clinics right next to the families where they were residing. And they came over there for their TB evaluation as well as their weekly dose of rifampicin. So of the 3,000 contacts that we evaluated, 39 were diagnosed with TB. 1,200 were started on preventive treatment, and we saw a treatment completion rate of 97%. And this was primarily because we took the treatment very close to the community. We engaged the NGO workers who were already working in that particular community, and they were close to the family members. So a slightly different model than Karachi, where people were asked to come to the health facility to receive their medication. Next slide. I would like to leave you with a story of a family and why preventive medicine is important. So a young man in November of 2016 in Pakistan is diagnosed with TB. We counseled the family to come for screening, but they refused. They did not want to come and identify with TB clinic. 6 months later, the young man's sister was diagnosed with TB. Still, the family refused screening. And about a year later, we continued working with the family. And about a year later, the family finally agreed to being screened for TB. And what we found was 2 additional members of the household were had TB disease, had contracted TB disease. So 4 people in one family, 3 of them could have avoided TB, went through the disease and its treatment. Subsequently, we worked with the family to start them on preventive treatment, and the rest of the family members started on preventive treatment and did not encounter TB again in that family. Next slide. Similar to that, DRTB, it's actually also very important to talk about the drug-resistant TB. It's a conditional requirement by WHO guideline at this point. We had initiated this at that time, and what we saw is a young lady was diagnosed with DRTB in August of 2017, and the family members were screened. 4 of the 5 family members agreed to start preventive treatment. The person who did not agree to start treatment got DRTB a year later. So again, importance of transmission within the families and the importance of taking TB treatment. I think that is my last slide. Thank you.
Thank you very much, Dr. Hussein, for the sharing of experiences. And of course, we can learn some things as far as having the private sector be on board as far as this program is concerned. So let's now go directly to our 4th speaker. I'm honored to introduce Dr. Masei Kawamura. She has been a TB clinician for more than 30 years and served as a TB controller in San Francisco, California. And it is during her term, really, that IGRA for TB screening in 2003 and gene expert TB testing for active TB diagnosis in 2010 were realized. Dr. Kawamura was previously the president as well of the North American region of the International Union Against TB and Lung Diseases, or the Union. So let's welcome to tell us or to share with us IGRA in the context of the latest WHO guidelines and if it's really feasible in our country. Dr. Kawamura.
Thank you, Dr. Joubert, and thank you to PhilCat for inviting me. I am trying to share my slides here, but it doesn't look like I can. I need to have some controls. Can someone help me technically, please? All I can share is a whiteboard, which I don't have. Okay, I will try to share again. I'm still seeing the same kind of screen, just the whiteboard. I'm not able to share. Okay, so I believe this is, so I had an updated slide deck, but I can go with this one. I have to go kind of rapidly, and I am missing one of the algorithms. So let's go ahead. My topic today is the role of IGRAs in the latest WHO recommendations on LTBI and how it can apply to the Philippines. Next slide, please. So I am an employee for QIAGEN, but my career has mostly been in public health, and TB elimination and prevention is really what I believe in. And so I hope this presentation will reflect that. Okay, next slide. So what has happened today is that the 2013 contact investigation guidelines recommending skin tests was combined with the 2015 guidelines for lower burden countries with rates less than 100 cases per 100,000 and put into a consolidated TB management guideline in 2018. And in that guideline, the big change that came in 2015 actually was the recommendation that you could use either the skin test or the interferon gamma release assay, or IGRA. But it was limited to the lower burden settings. In 2018, it was no longer limited to lower burden. It was basically, you can use it if you have it. They still preferred the skin test for certain populations. So now we come to the 2020 operational handbook. Please go to the next slide. And this is the first module is actually on TB prevention, and there'll be more modules to cover the rest of TB control. It is a handbook. It is actually meant to be an implementation guide and provides practical advice on the WHO guidelines. There are 18 recommendations on prevention, and they cover the critical steps and the cascade of preventive care that you so nicely saw in the previous presentation by Dr. Hussein. In this guideline, applying to the testing, again, there's no change on the recommendation of TST or IGRA from the 2018 regimen. Recommendations. However, there are other main changes. There are actually 9 changes, but to me, the most important ones is the addition of using the 1 HP or 1 month daily rifapentine INH regimen. Boy, I'm excited about that one. And the 4R or the 4 months of rifampin alone, in addition to the other guidelines. So they can both be used as alternatives. And there's additional advice in certain clinical situation on treatment for pregnancy and in HIV using rifapentine with some of the antiretroviral therapy drugs. Next slide, please. So what this guideline has is what they call implementation considerations. And they want you to use the best available evidence to ensure that you maximize the benefits and outweigh the risks to the individuals that will be tested so that you make the best possible use of the resources. But they also state that, additional resources are clearly needed for prevention programs, especially if you're bringing them up from scratch. And it's very intensive, as you saw in the last presentation. But the lack of funding should not be used as a barrier to actually working, but you should be used as a call for action to mobilize more funding. So basically what they have done with these implementation considerations is they've actually combined the 3 previous recommendations and put them into context in the implementation considerations. And we'll go through some of them in the next slide. And then they've actually made a single algorithm out of the 4 algorithms in the 2018 guides that were really complex. And when they talk about the systematic LTBI testing part, here's some of the implementation considerations. I think the most important one, relevant one, it's not the most important, but in terms of, there is some subtlety in this consideration. They say confirming LTBI with a positive IGRA or skin test, and reliable exclusion of active TB with a chest X-ray would be desirable before starting TB treatment or TPT. But they also state that if the tests and the X-rays are not available, this should not be a barrier to be eligible for TPT, and that you can actually rule out active disease based on clinical grounds alone. And then very quickly, they also strongly recommend ethical issue that they point out the ethical issues around LTBI, because it is you're a healthy person and it's not a contagious condition, and so you shouldn't treat them like an active TB patient who is contagious to others. And then you also should include a human rights approach, because LTBI disproportionately affects individuals and groups that are already disadvantaged, and often they're culturally different, and so you should really make every effort to reduce stigma and to meet them culturally, have laws and policies to protect their privacy, as well as to make sure that they have equal access to testing and treatment. So next slide, please. So this is the cascade of care, and I originally thought this was the one algorithm, and it sort of is, but it isn't. But so basically it's this: you're going to target your population, not at the top there, and you're going to do active case finding by looking at symptoms. If you have symptoms, of TB and you become a suspect, you will be going down the left side of that algorithm. If you don't have symptoms, then you're going to get tested and you're going to be assessed for TPT. Of course, that includes ruling out active TB, and then you're going to give the TPT. So if you follow the algorithm on the right. But please note, I've circled in yellow an asterisk, and that asterisk, if you go to the bottom to the asterisk, it does not require that people living with HIV or children, household contacts that are under 5 require testing, or for that matter, chest x-rays. And in the more elaborate one algorithm, they break the algorithm up into 3 parts and they are all interacting. And only the children and contacts over 5 get testing and chest x-ray. And you can see in the top box there, it's blocked by my, the icons there, but there are 5 different categories. You know them well: HIV, household contacts, and they break it down into under 5 and 5, medical risk factors. And there's the population risk, and these are the congregate settings that include healthcare workers, prisons, and also immigrants and homeless, etc. And then there's that other group, that additional risk. I think that the Philippines has taken a step forward by including people with diabetes and smoking and other risk factors who are contacts to screen them and to prioritize for treatment, but without the need for testing because of the risk-benefit ratio. Okay, next slide, please. I think I want to skip this because of time. You can go ahead. So I wanted to talk here about why, if you're going to test, why test accuracy matters. Now, if you're not a suspect for TB, you're going to get tested with either the skin test or an IGRA. And if you're positive, then you have another part of that workup. You have to do a chest x-ray. It also includes a medical evaluation to evaluate whether you're appropriate for LTBI treatment. Now, to be honest with you, from a program perspective, because I was a TB controller, this is actually the easy part. Not so easy if you're using the skin test and they don't come back for the reading, but this is the simpler part. The more difficult part, please forward to the next part for the slide. The more difficult part, as Dr. Hussein really elaborated on, is actually the treatment to educate that patient, to motivate that patient to actually take the medication, as well as make sure that they know what the side effects are so that they come back. There can be laboratory testing that is required depending on their situation. And then there's the clinical monitoring. And the standard of care is actually monthly visits to providers to make sure they're not developing any adverse effects from the medication, especially hepatitis, and to monitor their adherence. Now, the creativity of how you do this can be anywhere, but and you saw some of that creativity in previous slides. And I love seeing that, because this is the hard part. This is the intensive work. And so you don't want to get it wrong. And it's always better to decrease the number needed to treat with a more accurate test. Okay, next slide, please. So this is a slide that compares the skin test to interferon gamma release assay using the latest quantiferon as the example. The quantiferon and the IGRAs are actually now the gold standard for new diagnostics for LTBI, as well as prevalence, national prevalence studies, pharmaceutical research, and vaccine research. And why is that? And it's also the test of choice for the best TB control programs in the world and in Asia as well. And why is that? It's because the results are electronic. You get results with one patient visit. The test is objective, and you're not reading a bump. There are internal controls, and with this new quantiferon, you actually can measure the CD8 T cell response, which provides a broader picture of the immune response. But the most important difference from the skin test is that the result is not affected by BCG. And so although the reagents are more costly, IGRAs are actually more efficient, objective, and accurate tools because the skin test often requires people to come back again, get tested again, and that is very, very labor intensive. So at the end of the day, IGRAs are much more patient and program centered. And also from a cost perspective, both WHO endorsed IGRAs are on the GDF catalog with public health pricing. Okay, next slide, please. Just wanted to show you very quickly that IGRAs are not new. The first quantiferin was actually FDA approved in 2003. And we're now on the 4th generation IGRA. It can be fully automated as a result of the changes made over time. And it has new antigens as well as new flexible blood draw options, so that if even for remote sites, there are ways you can get that blood to a laboratory if necessary. Okay, next slide. Okay. the other IGRA, it's not an ELISA, it's actually an ELISpot IGRA. And this one is called T-Spot TB, and it was FDA approved in 2008. The procedure in the laboratory is much more laborious, and that's why that you don't see massive scale up throughout the world with ELISpot. They've also had problems because you have to get it into the lab and process within 8 hours. So they have they got T-Cell Extend approved in 2010, which allows you to process the specimen up to 32 hours. It doesn't extend the life of the T-cell, but it actually removes the granulocytes from the sample, which interferes with the performance. Even with that, however, there are studies, including the US CDC TB trials using Extend, showing different performance compared to the standard performance of T-Spot, which is very close to, if not slightly better than the older versions of quantiferin. Now, the head-to-head version of quantiferin compared to T-Spot shows better performance by the 4th generation quantiferin. Okay, next slide, please. I'm getting very close to the end of my presentation. I wanted to show you this brand new article that was published in Lancet. This is on the progression to disease from latent TB. And this is the largest systematic review that included over 50,000 patients, 40 publications, and 41 cohorts. You can see the indications on the left side of the screen. So most of them were contacts, but you see all of the other risk groups that you would want to screen for tuberculosis. And you can also see that on the right side, that not all the studies came from low burden. The little less than a quarter came from high burden, and half of the studies came from intermediate burden. Okay, next slide. Next slide, please. Yeah, so the result on positive predictive value, predicting the whether or not, how good the assays were at progression to disease from latent TB. There was key finding that the interferon gamma release assays performed much better than the skin tests. Overall, it was 4.2% compared to 1.6% of the tuberculin skin test in the head-to-head trials. And you can see that quantiferon's PPV, or positive predictive value, was actually the highest at 5.1%, with T-Spot coming in at 3.6%. When they included all of the studies highlighted in red and below on the lower table, you can see that still the interferon gamma release assay performed better overall, 4.5% compared to the 2.3%. So this was a very important finding because this is was not analyzed by the WHO. Please go to the next slide. Next slide, please. So the author actually concluded that the higher predictive value of progression for interferon gamma release assays, is equal to better targeting value. And then, that the interferon gamma release assays identified fewer people with LTBI because of the higher specificity. So they said that compared with the tuberculin skin test, IGRAs cost more for detection, but the cost of managing LTBI might be reduced because you're actually treating fewer people, right? So this is where we have found in the United States, because we use it extensively there, and we've been doing prevention for 40 years, that IGRAs can reduce costs because you're actually reducing the number needed to treat. And so in the United States, all foreign-born individuals from higher burden countries are recommended to get tested for LTBI. And the preferred tests for this population are IGRAs. So the next slide, please. I wanted to just end here and compliment the previous speakers on their efforts to prevent tuberculosis in innovative ways, and the Philippines plan to attack this great reservoir. And just to remind you, this is a New York Times article that just came out a few days ago, that the biggest monster is not COVID-19, it's really TB. And although our energies, even my energy is focused more on COVID-19 now, the real important focus should be on, we should not take our attention away from TB and this giant reservoir that will continue to kill people, if we don't do anything about it. So thank you very much for your attention, and I welcome your questions, and I'll answer them on the Q&A chat.
Thank you very much, Dr. Kawamura. And that's right. To our 4 previous speakers, please take some time to possibly answer the ones typed at our Q&A panel, so that we can manage and really allow more time for some interaction after our last speaker. So our last speaker for this afternoon is Dr. Irene Flores. I would like to welcome her to possibly share her experiences as far as telecontact tracing and TPT provision amid this pandemic. Dr. Flores is currently the co-chair of the Central Luzon TB Medical Advisory Committee, and she's also a TB satellite treatment center physician at the Jose B. Lingad Memorial General Hospital. So it is my pleasure to welcome Dr. Irene Flores.
Thank you, Dr. Jubert. Let me just share my slides. What's happening? I'm sorry, I share. Can you see my slides? I'm sorry.
Doctora, we cannot see it. Kanina meron and your title slide flashed, and then suddenly it's a white background.
Dr. Flores, I think you're showing the whiteboard. I think you have to show the PowerPoint.
Okay.
Yeah.
Yeah.
Now we can see your title slide.
Okay. Sorry. Okay. Okay, can you see my slides?
Yeah. What's flashed right now, Irene, is the title slide, the orange background.
Okay.
There. Is this your first slide?
No, no, this one is the
The
second slide. Sorry.
catalytic model?
Yeah, this is the second slide. Sorry. Let me go back. Okay. So good afternoon. Thank you, Dr. Joubert, for the introduction. I'm here to share with you our initial findings in the conduct of TB preventive therapy in our facility, which is Jose Bilingad Memorial uh, General Hospital. I will be presenting some of the challenges that we have faced in the process of contact tracing, screening, and evaluation amid the COVID crisis. Because we have a relatively new protocol in the TB preventive treatment, as discussed by our experts, I hope that this discussion will serve as a catalyst to find our undetected or missing TB cases, prevent the spread of the disease, and eventually eradicate TB. Oops. Okay. So as presented, we start with our index patients. These are bacteriologically confirmed drug-susceptible TB cases that we have identified through the mass screening conducted through the efforts of JBL-MGH DOTS Clinic and the TB Innovation, as well as inpatients, referrals from the hospital wards, and referrals from different rural units in Pampanga and nearby province of Bataan. We have a dedicated person, a trained health worker who does the contact tracing of the household contacts, including initial profiling and screening using the contact investigation form. The household contacts were referred to the DOTS physician for teleeducation and TB symptom screening. Afterwards, patient schedule was arranged for clinical examination and conduct of further laboratory screening and workups such as chest x-ray, expert NTB-RIF test for those who are classified to be presumptive TB, baseline liver profile test for those who will begin the TPT, and further Further management of treatment, either with TPT or anti-TB regimen, was based on laboratory results, clinical symptoms, and other pertinent clinical history of the patients. Clinic visits were limited to performance of initial clinical examinations, conduct of laboratory examination, and additional education and counseling during the initiation of TB preventive treatment or anti-TB treatment regimen. Monitoring of adverse events were scheduled every 2 weeks by the dedicated health worker, and the patient was also advised to report any untoward symptoms anytime. Okay, next slide, please. We identified 19 index cases, and out of the 19, only 17 consented for screening. 2 patients did not consent due to limited transportation, stigma, and preference to do his or her own household contact screening to avoid exposure of the household contacts to the hospital where he or she is working. Of the total 68 household contacts identified, 59 consented and completed screening. The reason for this will be discussed in the succeeding slides. Next slide, please. Majority of the household contacts belong to the working age group, 15 years old and above, with mean age of 27 years old. There is slightly higher percentage of females, 53%, over males, 47%, who consented and completed screening process. Next slide, please. So this one, I want to walk you through the horizontal diagram showing the steps done from first contact tracing process or an identification of the index cases, screening and diagnosis using signs and symptoms, chest x-ray, and expert MTB reef test to the initiation of the TB preventive treatment and initiation of TB treatment for identified active cases. So under the contact screening, the orange box, 17 or 89% of the index cases consented for screening. Of these, 68 household contacts were identified. However, only 59 or 87% of these contacts consented for screening. Out of the 59 who consented to be screened, 27 or 46% failed to complete the screening process prior to this presentation. TB screening or identification of presumptive TB cases was done using TB symptom screening and or chest x-ray depending on the age of the clients. So of the 59 household contacts, 3 groups were identified, and my line of discussion will be the cascade for each group. So those under symptom screening only, there is one case where chest x-ray is not done because the patient is less than 1 year old and not a presumptive TB by symptom. Hence, the patient was given TPT. For those under symptom and chest x-ray, which is 53%, 77% has no signs and symptoms, and with chest x-ray findings not suggestive of TB. They were all started on TPT. The remaining 25% still, although eligible for TPT, is still pending for final decision. 23% are with symptoms and or chest x-ray findings suggestive of TB. 83% of which were tested, and only one need to recollect sputum because of poor quality of specimen. At that time, the patient has hemoptysis. So all expert results were negative. However, the patient decided to treat all the cases as clinically diagnosed TB cases. There's still one case for schedule of expert testing. These are new cases that we just identified. Under the not done, 27 or 46% of the household contacts were listed. Our pilot testing is ongoing, and these cases are either for schedule of screening in the hospital or follow-up or referred in the centers or RHUs. In summary, a total of 19 or 32% of the 59 household contacts who consented for screening were initiated with TPT, and a total of 5 or 8.5% were initiated with the anti-TB treatment. Next slide, please. So from the previous slide, the proportion of household contacts that accepted screening is 89%, and the proportion of those who completed chest x-ray was 53%, while 46% consented for screening but still in the process of completing chest x-ray and clinical evaluation. So all 19 eligible for TPT were initiated with treatment. 4 or 21% belongs to less than 5 years old, and 15 or 79% belongs to more than 5 years old. All those who were diagnosed with active TB disease were initiated with anti-TB treatment. Next slide, please. So this slide shows the average lead time from initial telecontact screening to conduct of a chest x-ray, which is 15.8 days. From the conduct of chest x-ray to submission of specimen, so we spent 8.5 days. And from the submission specimen to initiation of treatment, is a total of 40.3 days. A total of 61.4 days lead time were spent from telecontact screening to initiation of anti-TB treatment. There is a long lead time from the screening to diagnosis for drug-susceptible TB cases, especially during the lockdown in the enhanced community quarantine, primarily because of limited means of transportation. Most of the families have no access to private transportation, although some of them have sought the help of the barangay or community leaders to provide them with transportation going to the facility. Still others chose to delay because of fear of being exposed to COVID-19 in the hospital. Next slide, please. So on the other hand, for TPT, the average lead time from initial telecontact screening to conduct of chest x-ray is 12 days, and from chest x-ray to initiation of treatment is 15.7 days, and there is a total of 31.2 days lead time from telecontact screening to initiation of TPT. There are several factors contributing to the long turnaround time. So first, clients coming from the different areas as shown in the map a while ago. So some need to travel for more than 1 hour to reach the facility. Second is the limited service day of the health facility doing the screening. So I can only do the screening every Monday, as is the only day I'm assigned to the facility, where we also need to take care of other TB patients, including those with multi-drug resistant TB. Third is the limited movements of the family due to community quarantine. So as mentioned, the lockdowns in the community have prevented the families to come physically for follow-ups. Sorry. No, I'm still using the other slide, sorry. So the availability, another problem is the availability and cost of public or transportation. So as mentioned also, public transportations are very limited and costly, although some have been fortunate to have active community leaders who brought them to the facility using the community service vehicle. Another problem is financial constraint. So although we are providing a free diagnostic workup in the facility, the same does not apply to the other health facilities. So next slide, please. To summarize, we have listed the barriers that we have encountered in the provision of TPT. So first is stigma. People are still afraid of being labeled as patients with TB because of its infectious connotation. Second, so we still need to cascade in the community level the updates on TB prevention and treatment. So at this moment, we have noted in our correspondence with most rural health nurses and physicians that they have not been updated yet on the new guidelines. So thirdly, fear of COVID. COVID-19 has cast a widespread fear for many people. Hence, they shy away from coming to the health facilities for consultations and follow-ups. We are very fortunate to have support from the hospital administration, non-government agencies, and the regional office of the Department of Health for cost of investigations. However, this is not the same for the other health facilities. Also, as mentioned previously, traveling can be very difficult for many because of distance and lack of access to public and private transportation. So limited service day, we can only give as much time as we can because we have also other responsibilities in and outside of the hospitals. Also, no communication provision for health workers. Health workers often utilize their own load for communicating with or follow up with patients. Another problem is the limited referral network for chest X-ray. Many of the chest X-ray facilities are located in urban centers, hence access is a challenge for many clients living in the periphery. So to facilitate these barriers, we have to strengthen our telecontact tracing, education, and counseling to the index and household contacts. We have assigned a dedicated person for the telecontact investigation through the help of the TB innovation. Third is to update guidelines on TMT. So we have been updated with the new guidelines for TPT from our recent training on Manual of Procedures, 6th edition, and hopefully to roll this out soon to the other health workers in the rural units in Region 3. We have trained and committed health workers in the hospital with one goal to stop TB. Another is we have free chest X-ray and test, free isoniazid for TPT, which are provided through the CHD fund. We also did home-based treatments, giving our clients 1 month supply of medication through treatment supporters in the family and constant communication with the rural health unit staff. There is established referral mechanism in place between Jose B. Lingad Memorial General Hospital and the local government units. We organized an online consultation feedback meeting with the local government units and region on the status of the implementation of TB preventive treatment pilot test. We emphasized and promoted the important roles of every partners in the success of the pilot initiative. So before I end, I think this is my last slide. I would like to mention that for any endeavor to be successful, we need good team partners. So may I congratulate also my partners in the facility, the STC nurses, and our STC head, Dr. Cheryl Magallanes. Thank you very much.
Thank you very much, Dr. Flores. And indeed, this was a fruitful afternoon, and we would like to thank, of course, all the participants who submitted their questions. We promise you that a link to the recording will be given to you. So please stay until the end so that the link will be shown here in our slides. And included in the recording are, of course, answers to the questions as well. Maybe I can have the panelists back to the virtual floor so that we can just have, some quick answers to some questions, which I found at least a common concern or a common thread across everyone. So maybe I can just direct the questions to particular panelists, and then we can have some sort of a rapid fire question and answer question forum. So maybe for Alan, Dr. Fabella. Alan?
Yes, Doc.
Yes, there was some question. Do you think a mandatory reporting for LTBI will help us accomplish the roadmap?
Actually, yes, Doc. Just like we implemented mandatory notification for active TB to document the private sector contribution, mandatory notification for LTBI will likewise help us because the information on actual coverage, including the private sector, will be important for decision making by the program.
Yeah,
Thank you.
there was a follow-up question to that. Are there any moves right now of really mainstreaming IGRA test in our national plans?
Actually, Doc, for now, the MOP recognizes that either TST or IGRA may be used. But in terms of actual activities to improve access to IGRA.
Yes.
Currently, it's not yet in the plan, so it will still have to be discussed.
Okay. Thank you for being honest. And so probably the next question is going more to Lisa Stevens' way. So Lisa or possibly Dr. Kawamura, there's some question here. How effective is TB preventive treatment? I think the main issue is that, as what you mentioned, repeatedly mentioned, we are treating asymptomatic individuals. And then with the possibility of that promise that if I'm going to give you this treatment regimen, you know, the possibility that you acquiring TB will be lessened. So how effective is it? Can we use it more than once? Those were the two questions. Lisa and Masay?
You want me? Okay, I can try.
I was on mute also. Go ahead.
No, go ahead. Go ahead.
Okay. Well, you know, preventive treatment is really effective, and that's why it's a strategy. If you're adherent to isoniazid for 9 months, you will decrease your TB TB reactivation or progression by 90%. And so, you know, it is very effective. Do you need to take it more than once? In truth, you do not. It should be a one-time deal. However, if you are immunocompromised, and there are parts of Africa, I don't believe the Philippines is quite like them, and you have very high rates of HIV, very, very high rates of community spread. They have found that extending or repeating preventive treatment, you know, up to 36 months can reduce that. And that's from getting reinfected, because immunocompromised individuals can get reinfected over and over again, whereas an immunocompetent person has immunity, right? So even if you get infected again, you're unlikely to get a very high rate of progression, like someone who is immunocompromised.
Lisa, any additional thoughts on that particular issue?
The numbers that are constantly sort of batted around for people with HIV is it decreases your TB risk by 33% across the board. But somebody who's got HIV and has a positive TST or IGRA who actually tests positive, it's more closer, it's like 68%. And also somebody taking ART and IPT or TPT is going to have even more effect and less a chance of getting TB. But I don't know the numbers on the under 5 context, but it, again, very effective medicine. And we heard the stories of what happens without it from Dr. Hamida. Thanks.
So there are signals there of hope and definitely of promise and the possibility that we have to do it and we have to give it, and then with that accompanying positive results. Maybe the next question is for Dr. Hamida Hussein. In terms of communication plan, as far as LTBI is concerned, what you think worked? How were you able to communicate it well? Was it really more striking on the fear factor, or was it striking more on, you know, public health issue? So for Dr. Hussein, what do you think worked as far as communication plan for LTBI management?
So I think it's a combination of both of what you said. There is stigma as well as a fear of the unknown. And also the thing of, I'm well, why do I need to take medication? Okay. You know, so there's all those possibilities. I think what worked was certainly a mass communication campaign. It was limited due to the funds that we had. So in Pakistan, what we did is programs on TV where experts went on and explained in very layman terms, programs on radio where people talked about why TB and what are the reasons other members are susceptible to TB, and actually what we need to do and where do they need to go to get care. Those kind of things really helped allay any fear of taking drugs, and also inform the public of what the new guidelines are.
Thank you very much for those inputs. I think this last concern goes in the realm of Dr. Irene Flores. So there was just some questions. Did you any experience as far as, you know, screening for COVID-19 as well during this time? TB screening and then possibly screening concomitantly for COVID-19 or vice versa. Irene, any experiences from your center?
Um, yes, doctor. From the facility, because in the hospital, we have a triage, a very good triage system. So all patients who are COVID suspects will be referred to the COVID ER.
Okay.
So no COVID suspect patients will go directly to the facility.
Did you have any yield? Meron, do you see any, you know, TB patients,
Yeah.
ambulatory TB patients, and then subsequently they will be COVID positive as well?
Um,
Not so much.
Not so much, but because we have seen patients admitted in the wards with previously with diagnosis of as COVID suspect, but later on labeled as TB. So they will be referred to us once the test is already negative.
Thank
So
you,
they will be
Irene.
selected for TB reef test.
Thank you. Thank you for those inputs. And again, on behalf of the Philippine Coalition Against Tuberculosis, we would like to thank all the participants and, of course, the panelists for sharing their time and expertise. This was indeed a productive afternoon. Bottom line, we have to grapple with this issue. Yes, this LTBI is here. Maybe it's, we always argue, is it are we going to hit the chicken or the egg, LTBI or active TB? I think we have to hit both in order to achieve our TB control targets. And with that, thank you for the panelists for sharing their expertise, the concepts, as well as the experiences, and of course, the lessons learned. We would like to close this afternoon session by hearing some remarks from Dr. Napoleon Arevalo. Dr. Nap is the director of the Disease Prevention and Control Bureau of the Department of Health. He also previously served as the regional director of the Bicol Center for Health Development. Dr. Arevalo, please.
Hello, magandang
Dr.
hapon
Arevalo?
sa lahat.
Yes,
Yes,
sir.
I'm sorry I came from a meeting. I was presiding a meeting, but I'd like to thank you all for today's hosting this event. And on behalf of our Undersecretary, Dr. Mirna Kabutahe, we thank PhilCat and USAID's TB Innovations and Health System Strengthening for hosting this important and very timely webinar on TB prevention. We focus our efforts not only in finding and treating people with TB diseases, but systematically looking for latent TB infection as well, if we are to prevent the progression to TB disease. This is a major strategy for us to be able to eradicate TB globally by 2035. Based on our previous year's accomplishment, the country has to catch up in the implementation of the TB preventive strategy, as we have expanded our target for the same, and setting the roadmap and policy direction in mainstreaming contact investigation and provision of TB preventive treatment to those who are at high risk of developing tuberculosis is the fire starter. To date, we have now the 6th edition of the NTP Manual of Procedures that would be our Bible in our road towards elimination. By the end of 2023, we need to reach 680,000 for TB prevention treatment as per our Philippine Strategic TB Elimination Plan. As we always say, The government cannot do this alone. And the role of the private sector is very crucial for us to be able to deliver. It would be needing whole of society, whole of government approach for us to be successful in our quest for TB to be eliminated. We must employ effective communication strategies for us to be able to create behavioral change, which is crucial to make us understand the value of prevention. And to our foreign speakers, our partners, our frontline workers, our colleagues in the medical community, we thank you for sharing your time for us to be able to learn from each other, share experiences and insights on TB prevention. Although the COVID-19 pandemic may have caused some disruptions in the delivery of TB care, we are optimistic that with the brand of Filipino resilience, we will be able to bounce back and rise to the challenge of TB prevention and eliminate it in the midst of the current pandemic. As our Undersecretary Cabotaje would always say, it is not enough that we do more. We have to act fast and now. We as a country cannot be left behind as we race against time to end TB. Once again, we thank all of you for the continued support and commitment as we take extra mile to implement effective approaches to improve the TB preventive strategy coverage in the country. Undeniably, it's time. To our heroes in TB control, to our partners, to our implementers, thank you and good afternoon. Mabuhay po kayong lahat.
Thank you very much, Dr. Knapp, for that wrap up. So again, I would like to thank all the participants and the panelists. And please fill out the evaluation form. I think the next slide will show the, yes, so you can fill out the evaluation form using this link. Please do let us know what you think worked. And of course, if there are areas for improvement as well. So we would also like to invite again everyone for the next PhilCat webinar. I think that will be next Friday. So raising the bar to improve TB testing in the Philippines. So August 19. So sorry for that. August 19, that's a Wednesday, 2 to 4 p.m. Raising the bar to improve TB testing in the Philippines. So we do know testing, yan ang parati ngayon nadidinig natin. But of course, as far as TB is concerned, there may be a lot of new things as far as testing. And let's see, this seems to be a really interesting topic. Again, don't forget to register. The link is shown as well in the slide. And in that note, I would like to thank, of course, again, the panelists, the organizers for this webinar, and of course, the participants. Please be safe, everyone.
Thank you, Jubert. Good night.